So the first practice management guideline is in regards to evaluation of the pediatric abdomen and who needs a CT scan for blunt abdominal trauma. CT of the abdomen and pelvis is commonly used to evaluate children following blunt trauma despite the low incidence of intra-abdominal injury found, the associated cost, and the risk of radiation-induced malignancy. This diagram shows our current clinical practice guideline for abdominal CT imaging in children following blunt abdominal trauma. The clinical practice guideline is a 5-variable model which identifies patients at extremely low risk for intra-abdominal injury in whom a CT of the abdomen can safely be avoided. The 5 variables here on the left are listed in the order of clinical availability and are as follows: complaint of abdominal pain, an abnormal abdominal physical exam. This would include tenderness to palpation, evidence of abdominal wall trauma like a seatbelt contusion or a handlebar contusion, abdominal distension, or peritoneal signs. Third, an abnormal chest x-ray. Fourth, AST greater than 200. And then finally, abnormal pancreatic enzymes, amylase or lipase. If all 5 variables are negative, then the patient is unlikely to have any intra-abdominal injury on an abdominal CT scan. I would also highlight the asterisks next to complaint of abdominal pain and abnormal pancreatic enzymes. These 2 variables had a much lower odds ratio for intra-abdominal injury, so I would highlight that CT is not compulsory in this model if only one of the 5 variables is abnormal and present. To highlight the practice guideline, I chose 2 patients. These are a brother and a sister from the same motor vehicle collision. The first, the brother, is a 6-year-old male. He was a restrained backseat passenger in the MVC. It was a car versus tree, a head-on collision. He had no stated loss of consciousness and was reportedly hemodynamically stable en route. In our institution, he met criterion for second-tier activation or level B. On primary survey, his airway was patent and his vital signs are as listed. His GCS was 15. On the secondary survey, the only finding was some mild tenderness to palpation over C6, as well as moderate abdominal tenderness to palpation over an obvious seatbelt contusion. The sister in the collision was an 11-year-old female. She was restrained in the back seat. She did state that she had loss of consciousness and was stable en route. Her vitals were fairly stable. GCS was 15. She had several fractured incisors and a minor lip laceration. Her midface was stable, and she had a normal abdominal exam. So some of the main considerations for trauma surgeons are: do you order labs and plain films in the trauma bay? Do you do FAST in your institution? What about a seatbelt contusion? In Alyssa's study, she mentioned in all 3 scenarios, the patient had a seatbelt contusion. And finally, what if the patient is intubated with a serious blunt mechanism like this, but no signs of abdominal trauma? So back to the 2 patients. The brother, initial hematocrit 37. His labs were normal. His AST was 49. His lipase was normal as well. And the chest x-ray had no evidence of traumatic injury. In contrast, the sister had 2 abnormal variables. Her AST was 222, and her chest x-ray showed some pulmonary contusions. Both patients underwent an abdominal CT. This is one representative cut from the brother. There are some small areas of free air and free fluid in the lesser sac behind the stomach. This was read as a suspicious for a hollow viscous injury. We brought the brother to surgery following CT and performed a diagnostic laparoscopy and a lap-assisted repair of a jejunal perforation. The sister also had an abdominal CT, which was normal. In regards to the 5-variable model, the model was derived following a study, which was a prospective study involving 14 level 1 pediatric trauma centers. This slide again highlights the 5-variable model and the percentage of patients with abnormal variable. IAI stands for intra-abdominal injury, and IAI stands for injury requiring an acute intervention. In this study, an acute intervention was defined as blood transfusion, an angiographic intervention, or an operation. As you can see from the slide, approximately 1/3 of the patients were identified as very low risk, meaning none of the variables were positive. Those patients had a 0.6% risk of an intra-abdominal injury, and a 0% risk of intra-abdominal injury requiring intervention. An additional 21% of the population were thought to be low risk. These were patients that had a normal abdominal exam and a normal chest x-ray, and who we chose to wait on lab. And in this additional 21% of the population, the risk of intra-abdominal injury was less than 5%, and the risk of injury requiring intervention was less than 0.3%, highlighting that it's likely safe in these patients to wait on labs prior to making a decision about abdominal CT. Our study conclusions were as follows. The prediction rule was most helpful in patients that were hemodynamically stable with a non-concerning abdominal exam. These are patients where there's likely time to get an abdominal CT, and less than 3% received an acute intervention. Most importantly, the vast majority of patients that did undergo operation, transfusion, or angio had an abnormal abdominal physical examination. Finally, abdominal CT scan utilization could be avoided in many patients by implementing the prediction rule. Even at pediatric level 1 trauma centers, over 23% of the very low risk population underwent an abdominal CT. And importantly, we saw significant variability between the centers, ranging from a CT scan use of 4% at one center to 96% at the high outlier. And then finally, we felt that this practice guideline would be very beneficial for the 90% or more of children that were initially seen in adult centers, where many ED physicians feel compelled to obtain CT prior to calling the pediatric trauma center and requesting transfer.
Thank you very much, Dr. Streck, for presenting such a clear protocol for a subject with variation across many institutions. Is there any role in doing a FAST scan?
This is probably the most common question I get asked. In particular, many of the adult ED physicians want to include FAST in any clinical prediction model. So what we found in our study was that FAST had a very low sensitivity for intra-abdominal injury. It was around 28%, and only slightly better for injury requiring intervention at 44%. And impressively, FAST missed the vast majority of injuries, both solid organ injuries like liver and spleen, as well as hollow viscous injuries. The solid organ injuries missed included grade 3 through 5 injuries. So these were not just minor solid organ injuries that were missed by FAST. And FAST also commonly missed patients that required intervention. FAST was initially designed for rapid assessment of hemodynamically unstable patients to determine the need for urgent intervention. It was not originally designed to determine who could safely avoid CT. We all know FAST is operator dependent, and then based on many studies in peds showing worse sensitivity of FAST for solid organ injury, I wonder if there's something different in kids. In conclusion, I do feel that there is a role for labs and plain films, particularly in hemodynamically stable kids with a concerning mechanism. They all don't need CT. I don't feel that FAST can exclude intra-abdominal injuries safely. And based on the practice guideline, I think that it is possible to be selective on who receives abdominal CT. Thanks.